So once again, let's dive into the information. I have several conflicts of interest just because I do a lot of drug development. None of them really should apply to today's talk, but I do put them up here just for everyone's information. So this audience is probably very well aware. Sadly, cancer affects a lot of families, and specifically we're talking about ovarian cancer, that over 20,500 women will be diagnosed with ovarian cancer this year alone in the United States. So it quite is an important disease and sadly does not have a lot of warning symptoms. So many patients are diagnosed when they're of a more advanced stage, meaning a stage 3 or 4. And then hopefully present to a GYN oncologist, somebody who can decide whether they're a good candidate for upfront surgery versus getting chemotherapy upfront. And the standard of care chemotherapy typically is a taxane and platinum and plus minus bevacizumab, which is one of our first targeted therapies that we have had now for over approximately 20 years, surprisingly, to target sort of vascular endothelial growth factor. And then in recent years, we've actually been able to add maintenance therapy for our patients, especially seeing huge benefits with patients who have homologous recombination deficiency in their molecular profiles of their tumor, or may have a BRCA germline mutation, so something passed along in their genes, versus something that might have just happened in the tumor microenvironment. So we're making strides and progress, but obviously there's still more work to be done, and we have lots to share today. First, though, I wanted to just briefly talk about some of the risk factors, because I think part of it is also all of our mission is trying to educate women so that they actually get attention so that maybe they can be diagnosed at an earlier stage. So first and foremost, ovarian cancer affects women of all ages. We do know that there is some association with being overweight or obesity, as well as some association with childbirth either later in life or never having had a full-term pregnancy. Some of the thought process is that if our ovaries are a little bit more dormant, which they happen to be during pregnancy, then there might be less damage to the ovary itself that causes maybe some of these cancerous changes. There is some data also about prolonged infertility treatments and hormone replacement therapy as well. And then there are, of course, some genetic syndromes that make you at a higher risk. So if you do have a personal history of breast cancer, that to be aware that you might be at a little higher risk for developing ovarian cancer. So when you do have a family history of cancer, I think it's really important to share your family history as well with your physicians so that you can get the appropriate genetic testing. Additionally, smoking has also been associated, and we mentioned some of the inherited genetic mutations. So what was new at the SGO was a lot actually about prevention and risk reduction. And the reason this is really exciting is just because of the fact we don't have a real good screening tool. So how do we try to prevent ovarian cancer when we don't have a good screening tool like we do for, breast cancer, where you can have a mammogram or maybe an MRI or even a biopsy that can be easily performed? So first we had to go back to where's the origin of ovarian cancer. And we now have really, with the help of our pathologist, learned in the sort of mid-2010 era that actually probably most ovarian cancers start in the fallopian tube. So what you're looking at is a fallopian tube here, and then this is sort of like a cross section of the ovary. So we do think that there's lots of precancerous changes that can happen in the fallopian tube. And then they develop some of these mutations called P53 as well. And then because the fallopian tube sort of sits right close to the ovary, those cells that are cancerous actually fall onto the ovary. And that's why we always think a lot of these are ovarian cancers, even though they may have started in the fallopian tube. It's also important to know that when we're talking about ovarian cancer today, I'm talking about really the high-grade serous ovarian cancer, which is the most common cell type of ovarian cancer. I'm not talking about endometrioid or mucinous, which are rarer cancers of the ovary, meaning cell type wise, or low grade. So I just want you to know that this is really how we think a lot of the high grade serous ovarian cancers occur. So genetic testing is really important, and it can be done either from collection from your blood or the saliva, and it's looking at your DNA to figure out if you have a germline mutation. So something that was passed either from your mom or your dad to you. And I really want to emphasize it can come from either side of your family, because a lot of, people really just are like, oh, this is a gynecologic cancer, so I couldn't have gotten it from my father's side of the family, but you really can. So it's really important to know both sides of your family. And I know a lot of families don't share their family histories, but also it's important just for health maintenance and trying to figure out who's at higher risk. Additionally, up to 25% of ovarian cancers are thought to be of a hereditary nature. So the majority are not, but we can make at least a really good impact on that family if we can understand if they do have a genetic mutation or not, because then there's something called cascade genetics, which is an opportunity to offer testing to other family members, whether it be the person who is affected with cancer to have their children tested versus just disseminating or giving that information out to their family members so they can talk to their physicians to get testing as well. So this gives you a way to prevent maybe or do risk reducing type of options. So this will bring us to our first presentation that was actually at SGO, and this was presented by Dr. Gutsen at SGO, and we're just talking about the BRCA mutations 1 and 2. So on the left-hand side, what you can see is if you are a BRCA1 mutation carrier, your lifetime risk of developing ovarian cancer is 35 to 45%. And if you have a BRCA2 mutation carrier, it's a little bit less, at 10 to 20%, and it tends to occur at a little later of an age group, so closer to 40 to 45, as opposed to BRCA1, where we do feel like it happens in a patient's 30s, and there can be even earlier patients afflicted with ovarian cancer. To put this in perspective, the general population risk of developing ovarian cancer without one of these genes is 1 in 75. So very different than breast cancer, which is about 1 in 8. And obviously these risk genes make you at a much higher elevated risk of developing ovarian cancer. So there are other genes which are also important, and they're called moderate penetrant genes, but it really has opened up to us that there are many more patients who warrant testing. And so now if you look at our testing, we don't just test for BRCA1 and 2, but we test for these other genes as well, which would be RAD51C, RAD51D, BRIP1, PALB2, just to mention a few. And you can see that they're genes that can cause cancer anywhere from as low as 3% to an additional 13%. So when you add all of this together, there's a significant number of women that we can prevent cancer as long as we know what their risk level is. So what is our current practice for offering risk-reducing surgery for patients? Is currently our practice is, this is a uterus, here are your fallopian tubes, here's your ovary, is really to take out your tubes and ovaries. And we sort of risk stratify based on what gene you may be afflicted with. So if you're BRCA1, we would offer, if you're done with childbearing, between the ages of 35 and 40, because we try to do it 10 years before the earliest member has been afflicted with cancer. BRCA2, it could be at between the ages of 40 and 45. And for the other ones, which were moderately penetrant genes, it could be anywhere from 45 to 50. So what are we doing is, by removing the ovaries and the tubes so early, is we're putting patients in a surgical menopause. So we know that we are afflicting their quality of life, because if anyone has gone through menopause, knows people who've gone through menopause, it's a big change in a woman's life in terms of how they're feeling and what's happening in terms of their quality. So some patients will suffer from mood disturbances. Some will have their hot flashes, which is what commonly people think of, sleep disturbances. in the short term when they first have that loss of ovarian function. But long term, there's even a bigger detriment to your heart health, your bone health, as well as to even your memory and your cognition. So we really need to try to figure out how can we improve what we're offering women. So this leads us to the study. It has a very catchy name called Tuba-Wisp II. And it really is including women to two different arms. One is they're accepting patients with BRCA1 or BRCA2 mutations. And this is a study that's being done international and worldwide. And you have your own option. So a patient can choose whether they want to do standard treatment, which is removing both the tubes and ovaries at the ages that are listed below. And then they're followed on a yearly basis to try to see how they're doing in terms of their quality of life. Have they developed any other cancers? Did they decide to go under other preventative measures because breast cancer is also elevated with these genes? And did they decide to have a preventative mastectomy? So there's a lot of long-term follow-up. And then option 2, which is the experimental arm, is looking at sort of a 2-phase way of doing a surgical approach. So the first is by actually just removing the ovaries alone at the recommended ages, a little bit younger because of the fact that you don't really need your tubes. And if you're done with childbearing, there's not a reason to necessarily keep them in place. Since you won't be disturbing your ovarian function, and that way you can also use it as contraception. And then having yearly updates, and then at a later date, when you are a little bit when you're ready to have your ovaries removed. And then have yearly updates. So you can see that it's exposing women to 2 surgeries, but overall the main goal is to try to improve the symptoms and the long-term effects of this surgical menopause. So what have we seen to date? This is really a trial that is accruing very well, as you can see, in the risk reducing removal of just the tubes. Over 1,500 women have participated, and in the standard of care, which is the risk reducing taking out your tubes and ovaries, 482 women have participated. And so far, you can see that really there has not been much of a difference in terms of the amount of cancers that have been found. So looking that it is very safe to perform this, as well as there did find sticks lesions, which if you remember from the couple of slides ago, those precancerous changes in the fallopian tube were found in some of these women as well. And so you can see on the right-hand side, the status of the patients who were found to have cancer, those 7 women, what happened to them. And you can see there is some women who have been found at an earlier stage by having had this surgery, since there was about 4 of these women out of the 7 who either had a stage 1 or 2. So the enrollment will not complete till 2027, but more importantly, the long-term follow-up will not occur till 2037. So we do have a ways to go, but it is very exciting to be able to offer women, because there's lots of women who are very hesitant to get their ovaries and tubes out at such young ages. And now they have an option and a way to also educate us for the future of how to take care of patients better. So that was the update on prevention and risk reduction, but what are the updates on maintenance therapy? So I want people to really appreciate, and this table is not meant to be exhaustive, but really to appreciate how far we've come. Because, I'm not going to date myself, but I've been doing GYN oncology for quite some time, and we haven't had maintenance therapies. And really with the advent of 2017 and 18, we started seeing all these great trials of offering patients PARP inhibitors for maintenance, and also giving PARP inhibitors with bevacizumab in maintenance. So we finally got to join the realm of, other cancers where you take your treatments and you actually have a treatment after that can maintain a response. And hopefully, as we've seen in the trials, continue to have a really good quality of life, which is also very important as we ask patients to take these maintenance therapies for at least 2 to 3 years. So, you know, it's exciting because there's always that scare when you finish your therapy, will it come back? And so this has been a real big advancement in ovarian cancer treatment. So maintenance options are really important, and we really try to stratify which patients can benefit the most from our maintenance therapies. And so we do know that the patients who have genomic abnormalities in this homologous recombination pathway, which is up to 50% of patients, whether it just be BRCA1, BRCA2, some of the other mutations I mentioned earlier, like PALB1, RAD51C, there's other pathways in the homologous recombination pathway as well, all could really benefit with the use of these PARP inhibitors, which impair your DNA damage repair, as well as we have our old friend bevacizumab, which can be utilized as well as a single agent or in combination with a PARP inhibitor. So we do have options for every patient to at least get something. So how do PARP inhibitors work? So this is taking people back to biology class a little bit. Remember, we all have DNA. Our DNA is double-stranded, as you can see in this top line, and it can get damaged. So we can get a single strand break. And then when we have that, what does our body want to do? They want to try to repair those breaks. And when you have a PARP inhibitor, it impairs the ability of that single strand break to be repaired. So you end up with a double strand break. And then when you don't have the ability to innately repair it because of the fact that you have this HRD abnormality or BRCA mutation, what will happen is that cell will die, so that the cancer will not have an ability to actually repair itself and will actually pass away, which is what we want. There are other ways to repair our DNA as well. And so BRCA is a very important way to help our DNA stay intact. So maintenance options, I will tell patients all the time, are like our lifelines. They're the ways to make this into a long journey by our ability to give patients these options of taking a pill when it's a PARP inhibitor by itself versus taking a PARP inhibitor with an infusion like bevacizumab, which also would cause the patient to come once every 3 weeks. However, the data is very compelling to improve our patients' progression-free survival, meaning that the cancer will not recur. So it is really a lifeline and a great addition to our armamentarium for a physician. So one of the things that we've always appreciated in ovarian cancer is that the immune system is very critical for every cancer, but especially in ovarian cancer. Going back to the early 2000s, we've known that if patients' tumors have a lot of what we call T cells that come in and sort of try to help, you know, clean up and kill the cancer, that they do better than patients who do not have that type of more robust immune response. But what we're also learning, and this picture is just meant to say that our immune system is very complex. So a lot of the drugs that we're going to talk about may target only like our T cells and not our B cells, or it only targets our innate, not our adaptive immune system. So when we talk about immunotherapy and we use that word, remember there's so many parts to this system that it's not fair to sort of say we're giving you an immunotherapy that's affecting all of this. So I just want people to keep that in the back of their mind. But it is an exciting time because we're finally developing medications to target our immune therapy and help our own bodies fight the cancer more effectively. So one of the drugs that has come about that people probably have seen the ads on TV is called pembrolizumab or Keytruda. And really what it is, it's an anti-program death 1 antibody. So what it really does is it tries to basically have your T cell be able to fight a cancer more in a more sophisticated fashion. So this is a way it sort of helps augment your own immune system, fighting this cancer cell down below. So one of the trials that got reported at SGO was really looking at adding Keytruda to our standard of care chemotherapy. So it was looking at patients who had advanced stage 3 or 4 cancers. They could not have had a BRCA mutation. And this was upfront therapy. So it was patients who had never seen any type of chemotherapy previously. They could have had neoadjuvant treatment, so meaning chemotherapy first, followed by surgery and then chemotherapy versus having had surgery upfront, but they would have had to be randomized to this trial. So the control group was looking at our standard of care, carboplatin and paclitaxel, along with placebos. So you were either given pembrolizumab placebo, so not getting any drug for immunotherapy, versus also getting an olaparib placebo, so a PARP inhibitor placebo as well. And then the middle arm was looking at giving the chemotherapy combination with a PARP inhibitor placebo, but you were getting the immunotherapy. And the last arm was you're getting everything. You're getting your chemotherapy, your pembrolizumab, along with olaparib and pembrolizumab afterwards. So they were all randomized 1:1:1, so meaning you had a 1/3 of chance to get into either arms in order to see how you did. And what it was looking for is to try to see what was your progression-free survival. So a fancy way of saying, when would it recur and would it ever recur, as well as your overall survival. And you had to, of course, have in all trials a good sort of inclusion status. So they were looking to make sure they were stratifying patients based on their surgical outcomes to make sure patients had the best surgical outcome, meaning no residual disease after a surgical intervention versus someone who may have had some disease left. They also looked at the race, because we are learning that we all sort of absorb our drugs differently. And so we want to be mindful of that. And one way to account for that is by looking at racial differences, as well as they looked at molecular biomarkers, because, if a patient has a homologous recombination deficiency in their tumor, they may respond very differently than somebody who does not. So what you can see is these were the progression-free survival curves for patients, and the combination group where they got the pembrolizumab along with the olaparib. So the blue line compared to the control, the patients actually did significantly better if they got the combination maintenance therapy, and that was statistically significant. So what does that mean is that it really showed not a statistical difference, but what I would talk to you about is patients had a bigger benefit. They had 8 months of a benefit by taking this combination, which is really important because it means that we're continuously moving the needle for our patients to the day where I hope we don't even need these type of curves, but at least showing that we are benefiting our patients by demonstrating that adding these medications can be helpful. This actual trial was first, I should say, presented at SGO, which is the European Society of SGO, 2 weeks before it was presented here in the United States, because this trial was an international trial. So they also wanted to look at if you got single agent pembrolizumab with chemotherapy versus just chemotherapy alone. And the plots here on the left really just show that they were not separated. And so because of that, they really did not have a big differential in terms of the months of a difference of improvement. So really, it does look like you need the combination of the pembrolizumab with olaparib to see the benefit of immunotherapy for this patient population. So this is just in a table format because all of us process information a little differently as opposed to graphically, but I think the graphs make it a much more significant point of how if you have the combination, it is better than just the single agent. And this trial will not be going forward to see a big significance in overall survival since it did not meet its sort of primary endpoint, which was looking at just the benefit of pembrolizumab alone. So it is definitely shows that there's an improvement for progression-free survival, but we still have more work to be done. One of the other things about any clinical trial is that it's important to make sure that we're not seeing new side effects or anything that would make it harmful to our patients as well, because we want to improve survival and quality of life equally. And so there was no new immunotherapy side effects. There's many side effects that can be occur with immunotherapy as well. And these are the ones that are more common. So thyroid issues, sometimes you get lung issues, as well as some colonic issues such as like diarrhea that can occur. So there was nothing that was new that was found. So that's also very beneficial for our patients. So in summary, I think it was a very important trial because it did show that there was a clinically meaningful benefit in progression-free survival for our patients. And the benefit was amongst all the groups, meaning even if you had more residual disease from after surgery or based on ethnicity. So it was nice that it was generalizable to the large group. And then they did see that there seemed to be even more of a benefit for patients who did not get bevacizumab with their pembrolizumab, but that's an exploratory analysis that they'll continue to look in to try to figure out, is there some type of signature that would also help us? And some of the patients did get the bevacizumab in combination with chemotherapy. So now moving along to platinum-resistant ovarian cancer, because sometimes patients will sadly recur after having gone into remission. And if you've gone into recurrence, which has been defined typically as 6 months or less from your last receipt of chemotherapy of carboplatin, then you're considered platinum-resistant. And so we really need more medications for this group of patients, and there's lots of exciting clinical trials that are ongoing. One of the trials that read out was a trial called Denali that we're going to talk about. But it's important to know that all of these trials are based in understanding the biology of the cancer in order for us to make better drugs to target these cancers, because each cancer type, even different cell types, an endometrioid cell type of ovarian cancer acts differently than a high-grade serous cancer. But one of the key things we've learned from the biology of ovarian cancer is that there is a protein called cyclin E1, which is important in what we call cell cycling. So if you remember your mitosis pathway. So we're bringing in biology again. Remember, the cells have to go through the different phases of the cell cycle in order for cells to continue to replicate and not die. So one of the master regulators of the cell cycle is something called WEE1. It acts as a brake between our G1 to G1 to S over here, as well as G2 to M in order to allow DNA repair. So if we target this and don't allow WEE1 to work with a drug called azenosertib, you would end up with what we call mitotic catastrophe, which means basically cell death. And why is this important, this cyclin E1, is that we've known for many decades, actually, that it is very important in realizing that if you do have this protein that's, quote, amplified in your tumor, that patients don't do as well, as demonstrated by this red line, compared to patients who don't have this amplification or abnormality in their tumor, where they tend to do better in terms of their survival. So really, there's been a huge push to try to find something that's effective in targeting this master regulator called WEE1, and azenosertib is that medication that's being evaluated. So this is a phase 2 open label study. So what that means is a phase 2 is that all patients with platinum-resistant ovarian cancer, as long as they meet the eligibility criteria, would be in a able to enroll. So this is not a randomized trial like I just showed you before with looking at the trial of KeyLynk that we just looked at with pembrolizumab. So about 100 patients were enrolled. They were allowed to take azenosertib, which is an oral medication. And then it was looking at the response and the progression-free survival of these patients. So seeing if there is an efficacy signal that can be seen in this patient population. So what they looked at is they looked at all comers, so all patients who were treated with this medication, and they got an overall response rate of 20.4%. So visually what you're seeing is this is all the patients on the left-hand side, and the patients who are on this right-hand side where this is showing the reduction of the actual cancer once they were given these medications. So what's so exciting when you see this is the deeper the bar going below this line, you really can appreciate that this is a deeper response. So the PR means that they had a partial response, and there was a significant number of patients who did. But, you know, we always want to try to figure out who's benefiting the most. And so what they looked at is what we call immunohistochemistry, where they stain the actual tumors of these patients. And when they use that as what we call a biomarker to try to figure out patients who had more cyclin E1 positivity, you can see that the response rate went up to almost 35%. So we got an additional 15% of patients who had an improvement based on just the stratification alone. So really encouraging that we could actually see that we have a biomarker, because that also helps us stratify patients so that patients don't get medications that may not benefit them, and really optimize what we're offering our patients. So this was really exciting because this is the first WEE1 inhibitor that has been able to be utilized with side effects that are very manageable, because there have been other drug companies that have had WEE1 inhibitors that have gone through clinical trials, but they were not thought to be as tolerable for patients, because that's equally important. And I'm sure some of you on this webcast have probably participated in clinical trials, and the only way we learn about not only the side effects that are medically that we can measure objectively in your blood or, you know, with scans, is also by knowing how you're tolerating with quality of life surveys or surveys that are looking at how you're performing with these medications. So you can see that it did have some side effects. Some of them are hematologic, meaning that they had decreased white blood cell counts or decreased, you know, they had more fatigue as well. So now I'm going to move to folate receptor alpha. There's a lot of enthusiasm about this target, mainly because of the fact that it is not found on normal tissue. It's really only found on cancer surfaces. And that is also important in terms of trying to minimize side effects, because some of the side effects from medications are because it targets both healthy and cancerous tissues. And folate is very important in DNA biosynthesis and repair and methylation as well. So it's a very important target. We've had an antibody drug conjugate that has been approved since November of 2022 in an accelerated fashion because of the exciting data that was seen. And then we got full approval from the FDA in March of 2024. So currently, what you can get this drug called mirvetuximab is if you have an immunohistochemistry score that's greater than 75%. Then you can get this medication. If it's greater than 50%, you can potentially get this medication in combination with bevacizumab. What's interesting about these antibody drug conjugates is that it is what I like to tell people almost like a smart bomb. It has the sort of target, which in this case would be the folate receptor alpha, and then it is conjugated or sort of attached to basically a chemotherapy-like medication. So something that inhibits tubulin polymerization, which is almost like a Taxol. So something that also affects the cell cycle as well. And because of the way these medications are formulated, you can give much higher concentrations of these, what we call payloads, that are almost like chemotherapy, without having the side effects for patients. So this was also read out here at SGO, was just more information about what we call Mirasol, a trial that was looking at platinum-resistant patients. And this was more to confirm what we had seen in smaller trials, the benefit of adding mirvetuximab versus patients who got standard of care chemotherapies like paclitaxel, Doxil, or topotecan, and then trying to see what their progression-free survival was. So this was a global study that was to be used as basically an open label phase 3 to confirm. And what you can see, it performed like we had anticipated. It actually showed that the mirvetuximab, which is in orange, did much better for patients compared to our standard of care chemotherapy. And this was really the overall survival analysis for these patients, showing a significant p-value, but more importantly, showing that up to a third of our patients had a reduction in the risk of death. So it really shows that patients can live longer, and we're making, as I said, impacts in the journey of our patients. So with this, there's so many different antibody drug conjugates that are really being studied. Some of the ones you may hear about are looking and focusing on HER2, on Claudins, on TROP2. So there's so many more exciting antibody drug conjugates coming out, and that will be hopefully available for future discussions. So I do think the future is quite bright. So I have some key takeaways for you as an audience. One, if you have ovarian cancer or it affects your family, make sure that genetic testing is performed, because it could hopefully find out if you are at a higher risk, even as a family member who's not affected, that you could do risk reducing options. Also, that we are trying to improve the quality of our risk reducing surgeries that we're offering our patients so that they can have a better quality of life. And we'll see some of that data of how it affects their sort of short-term as well as long-term health. And then immunotherapy right now seems to, at least the immunotherapy as we define it with checkpoint inhibitors, with chemotherapy has benefit, but it's not as helpful. And there's newer and other trials ongoing with other sorts of immunotherapy that I think might show a bigger benefit for our patients. And then on top of it, there's lots of different medications that are still going through clinical trials. And I hope that everyone can understand how important science is to really make a difference for our patients and our whole society in general. So I am going to put a little plug that the NIH really helps a lot of this. And so please be also active in, advocating to support these measures, because this is a way we lead the world in terms of better treatments for our patients. And with that, I want to thank everyone for their listening to me today, and I look forward to the questions.
Thank you, Dr. Thaker, for that incredible presentation. You were able to cover a lot of ground, so we really appreciate that. And so, yeah, let's now start the Q&A. You can still submit questions in the Q&A section at the bottom of your screen. We will try to get through as many questions as possible in the remaining time, but we already have a lot. So let's dive right in. Off the bat, there were several questions about genetic testing, so I just want to touch on some of those. One person indicated that they were told that their cancer was BRCA-like, but that they didn't have the genetic mutation, and so they're wondering, what is BRCA-like, and is there a specific test for this?
Yeah, so I think BRCA-like, or BRCA-ness as sometimes it's referred to, is really saying that you have a homologous recombination deficiency abnormality, because what some of us will do is test your tumor first and get there's lots of abnormalities, because it makes a lot of sense that your cancer is going to be the most abnormal part, right, compared to your genes. And then there is part of that testing that comes back that says you have a homologous recombination deficient positivity or negativity, and it depends on which test is utilized, because there's Myriad, Tempus, Caris, lots of different commercial vendors. And based on that alone would make you a good candidate for potentially PARP inhibitors plus minus using bevacizumab. But it doesn't mean that we're worried that you have an increased risk of actually something in your genes. That being said, there are some patients who will opt to get tested still, because there could be a very rare patient that still, it's not detected in the tumor, but has a mutation. So every patient has the opportunity to get tested, but it depends on whether you want to or not. I will say I tend to test tumors first and then offer the blood test, but I know there's lots of people who will get both done simultaneously or do the reverse order, especially, sometimes none of these tests are perfect. So family history, I think, is also very important, because I wish we could blame everything on our genes, but overall, as you saw, only 25% are really, quote, genetic. So the most we don't know why and want to know why.
Mm-hmm. And so that's a good segue to some of the other questions about
Yeah.
genetic testing. And so this person has high-grade serous with no known genetic family origin, but she is wondering if she should encourage her daughter to get genetic testing, and if so, at what point?
Yeah, so that's a great question. Actually, that's why it's really important for the person who actually has the cancer to get tested, because what otherwise happens is there's always this doubt of, was it genetic or not? And if the person who has it, the mother, doesn't have it, then it can reassure the daughter that you're at the average risk of the population. Because genetic cancers also tend to happen earlier. So that's why you saw our risk reducing options are done in your 30s or 40s, because we're trying to prevent the cancer in the 40 and 50 range, which tend to be more genetic. The ones that are a little later in life, like in 50s, 60s, 70s, we feel are less likely. So I would encourage the mom to actually get tested to save the daughter from getting maybe unnecessary harm, because there are actually there's sort of studies that have looked at patients who are at normal risk, meaning not having a genetic mutation, and you get a lot of patients getting unnecessary surgeries, because every cyst that is found on an ultrasound is always a concern, and then you just get a lot of anxiety as well.
Great, thank you. And so then on the flip side, this person is asking about, in instances where there's no knowledge of family history, example, adoption or something like
Yeah.
that, do you recommend genetic testing? And if
Yeah,
so, at what age?
sure. So I would say if there's somebody afflicted with cancer and they're adopted, they're really, most patients, when they're adopted, are not necessarily going to get tested proactively, because we don't recommend that the general public just get tested for this, because there's also a lot of, we don't just test for 2 or 6 genes. These are panels that test for like 70 genes or things like that. And, so there are some commercial companies that are directly marketing to patients to get tested to know your risk. A lot of those, sadly, right now don't have very wide population data. So they're based on maybe few hundred patients who are all Caucasian, which, most of us realize our mix up of our genes is multifold, like no one's just pure this or pure that. So it is hard right now to say everyone should get tested. So really, I would talk with your physician, what is your risk? Because we didn't also talk about birth control. Pills are thought to be preventative. So, if you've taken birth control pills at any point in your life for at least 5 years, we know it decreases your risk by 50% of developing ovarian cancer later, because of this sort of thought that your ovary is not incessantly what we call ovulating, making an egg and rupturing, because the birth control pills sort of contain that environment. So I think it's really a discussion to have with your physician about what the risk benefit is, because, we think everything knowing is sometimes beneficial, but for some patients, it can be very anxiety provoking, and debilitating as well.
Great, thank you. And I know when we were discussing it, you mentioned that there were no specific updates on rarer forms of ovarian cancer, but we are getting a couple of questions about that. So I'm just wondering if there's anything you want to highlight for patients with some of the rarer tumor types.
Yeah, so what I would say is, at this meeting, there wasn't for the rare tumor types, but for like clear cell ovarian cancer, which we know is what we call more chemotherapy resistant, not as, receptive to the Taxol carbo that we give patients. There was good data presented at ASCO and ESMO, other big conferences within the last year about using something like a PD-1 inhibitors, so using and a CTLA-4 inhibitor, so called nivolumab and ipilimumab, and they actually saw a benefit for patients to use immunotherapy. So it does look like that is one cancer where immunotherapy is beneficial compared to where we usually only see response rates of 5% with chemotherapy. They saw responses of close to 20 to 25% with immunotherapy, so still an improvement with very tolerable side effects. I think one of the other big ones that we've been following at several conferences is, we are talking right now about high-grade ovarian cancer, that you can also, there's low grade, which isn't as chemo responsive. And so with that, you can use something called a MEK inhibitor. And with a FAK inhibitor. So it's defactinib is the FAK inhibitor, and the MEK inhibitor is evimutinib. And that is going through right now into a phase 3 trial, which is very exciting because it's a very rare tumor to begin with. Only about a couple thousand women are affected every year with it. And so we're getting exciting results with that. So hopefully we'll have maybe an approval at some point for rare tumors, because I sit on the NCCN guidelines, and we always have, very low level sort of evidence because they're small trials, but this would be exciting to have, another trial that could be for recurrent disease, because we do have approvals just for a MEK inhibitor alone, but we haven't had one with the dual agents, so it's quite good.
Yes, we'll be watching that closely.
Mhm.
And specifically for clear cell, could you indicate if any of the immunotherapies or other treatments you discussed today work on clear cell ovarian cancer?
Yeah, so by itself, I wouldn't say any of the PD-1s or PD-L1s really are helpful. There have been some suggestions that they may benefit from, the addition to chemotherapy, but a lot of the trials that we've looked at haven't had enough numbers yet to know, because a lot of times they try to quote homogenize the population, so meaning trying to have cancers that they think will act similar, because if you have these one-offs it's hard to do. So we do have some of these trials. That's why it was so exciting to see this clear cell trial happen, because they really only had 45 patients, and it took them over 3.5 years to accrue 45 patients because of the rarity. I put in the chat, I'm sorry, the names of the drugs for the clear cell. I should put for clear cell. Sorry about that. But I spelled it out for you. So that's what I was looking and doing at the same time. So sorry.
No, thank you for answering that in the
Uh,
chat. So switching gears a little bit, is there something called PARP2 that works like a PARP inhibitor but has fewer side effects?
Yeah, so there are some newer PARP inhibitors that are being developed. They're called PARP1 selective or PARP2 generation, to be looking to see if it can cause less side effects. So meaning less issues with having anemia or some of the nausea or fatigue. But, they are reading out slowly because there's such enthusiasm for patients to want to go on the PARP1, the other generation, since they're approved. But yes, there are.
Great, thank you. And then we're getting a question about whether in patients who are BRCA positive, will have the BRCA mutation, is it beneficial to have a mastectomy?
Yeah, so I mean, that is the issue with the BRCA genes, and I tell families all the time, is that we're good in saying you're at a higher risk, but not all families will have both. There are definitely some BRCA families that all they have is breast cancer, and I don't mean that disrespectfully, but they won't have any patients with or family members with ovarian cancer. And then there's others who have just ovarian cancers that are and have no breast. So I think it's really worthwhile to meet with a breast surgeon, talk about the how you can be screened, because some patients will be offered MRIs alternating with mammograms in order to prevent mastectomies. Some will be also offered tamoxifen or other, hormonal agents to try to prevent. So it is a combination.
Does it depend at all on the age? Like if this is an older person?
It can depend a little bit on the age, but I think it's more of what is your sort of, I'd say psychologically, it's a lot different to go through a mastectomy as well. So I think it's really very individualized. It's not only age dependent.
Mhm. Great, thank you. And then this question is asking whether everyone should be, I'm assuming they mean ovarian cancer patients, should be on beta blockers due to the research that stress contributes to the development, outcome, and recurrence.
Yeah, so that's somebody who looked up some of the research I do, which is great. I would say I can't recommend that you should definitely be on it, but I definitely think it's not a harmful medication to be on. Because beta blockers I tell people are used for like stage fright, anxiety, migraines. So in the world we live in today, it may not be a bad idea to be on a low dose, especially currently with all the news events of everything going on.
Great, thank you. And then this person is asking your opinion for HRT for high-grade serous patients who went into surgical menopause at a younger age. Can it increase the risk of recurrence or other cancers?
So I think that's a great question. And that's actually what I think a lot of this, sort of prevention is trying to get around, because we do leave women with these side effects. And so we do have data from some other trials that look and see that HRT can be beneficial for women, but they do have to be, equally monitored, especially when they're BRCA for breast cancers, because there is some even though we give you medications, it's not exactly always as balanced as we think. There's not like levels we can monitor. It's usually by symptoms that we look for. So you just have to be keeping up with your other preventative measures, but it can be given safely and doesn't increase your risk
Mhm.
for other cancer development.
Okay, great. Thank you. And then someone's wondering if there's any progress or news pertaining to an ovarian cancer vaccine of any sort.
There hasn't been. There was a lot of excitement for a treatment or a therapy, and unfortunately, when it went into a more advanced or stage trial, it did not show benefit. So I think that is still something that everyone is working on. That's why I think there's a lot of work that still needs to be done on prevention, or trying to figure out what sort of initiates all this. Like finding the fallopian tube is a very big part of that, but that doesn't explain all cancers, or, because we're using ovarian cancer to encompass ovarian, fallopian tube, and primary peritoneal. So it's a big basket that we're trying to capture.
Mhm. Great. And then we're getting a question about if approximately 90% of us are T53 positive, why is this not being studied more? Is there anything on the horizon for this?
Yeah, so P53, actually there are molecules that are in development to look at that. The reason it's been so difficult is P53 is a master regulator of all of our cells. And so, like I said, it's trying to find that correct balance between normal and cancer cells. So even our normal cells have P53. So it's a mutated version that's a problem. But if you give a drug that hits P53, quote unquote, globally, you're going to have a lot of targets that are not going to be really compatible with sort of ease of taking it, because a lot of these are medications, like any of them, when we look for effective medications, we have to make sure they're also not harming other vital sort of organs or structures or functions for patients. So it's a great question. I mean, there's lots of other cancers that also would benefit from P53. So people are trying, and with the newer technology, we may be able to, especially with these encapsulations. So it's not sort of given truly in your whole system and can hopefully target those abnormal cells. So I say stay tuned, because that is a very good question, but not yet ready for prime time.
Great. And I'm looking at the time. I think we can squeeze in one more question. So just switching gears again, but wondering if you can discuss trastuzumab deruxtecan for
Yeah.
ovarian cancer, including HER2 low expression.
That's a great question. So, that actually there was a lot of excitement because that was also presented at the European Society of Medical Oncology. It's a basket trial. And for the first time, gynecologic cancers like ruled in that trial. Like all of the gynecologic cancers did very well, meaning ovarian, cervical, and endometrial. But they were really looking at 3+ and 2+ patients for IHC, so immunohistochemistry. And that data was based on 40 patients. So we saw these really robust responses, but we are really trying to now go ahead and replicate in a larger trial to see that that's what the responses are. And they didn't really see much of a benefit for 1+, but there are other medications going through for breast cancer that might be ultimately beneficial, because we do know long ago, about 15 years ago, we looked at trastuzumab in ovarian cancer and didn't have a very good response rate. The last question I did like in the chat is lack of research funding or problem in treating and increasing survival in ovarian cancer. Yes, it's under attack. I would say women's health, sadly, is under attack in general. So it's not only our cancers, but our contraception, our other reproductive rights. So I do think advocacy is great, not only for cancer, but just women's health in general. So if you can, please be mindful and try to advocate, because the only way we can continue research is with funding and dollars. And a lot of, as you're learning, comes from the government. Pharma does a lot too, but we need everyone, right? Because we need funding in general. And even before all of this, one last thing, men's cancers are much more, have many more research dollars than women's, and now it's even worse. So please write, and advocate. Foundations, philanthropy, all of it is important. So every dollar matters.
And just with that, there's some good organizations. Our Ovarian Cancer Research Alliance and FORCE, they do a lot of advocacy around this. And of course, Foundations for Women's Cancer. So keep an eye on those organizations, because sometimes they have opportunities where you can reach out to your representatives or even participate in advocacy days, because that is so important now more than ever. Okay, with that, thank you so much, Dr. Thaker, for that incredible presentation and answering these questions so thoughtfully and so thoroughly. We really appreciate it. And thank you to everyone who joined us today. We'll have the recording of this program available on our website in a few weeks. Please check SHARE's website for upcoming educational programs and support groups. And don't forget to follow us on social media as well. Please take a moment to complete the survey at the end of the webinar. The survey will pop up in the browser when the webinar ends, and the link will also be in the follow-up email. All surveys are anonymous, and we really use that feedback to inform our programming. And so with that, that concludes today's webinar. Thank you again, Dr. Thaker, and I hope everyone has a great rest of your day.
Thank you. Take care.